Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the website qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary. For the medical knowledge to general people and for reference to medicals. Today, I am going to discuss about the oblique inguinal hernia. It is the protrusion of a viscera or a part of it into the inguinal canal, which has three parts: superficial inguinal ring, deep inguinal ring, and inguinal canal. Superficial inguinal ring. It is a triangular opening in the aponeurosis of the external oblique muscle. The ring is bounded by superomedial and inferolateral crust joined by crisscross intercrural fibers. Normally, it won't allow even the little finger. Deep inguinal ring. It lies above the inguinal ligament and midway between symphysis pubis and anterior superior iliac spine. It is a U-shaped condensation of transversalis fascia and open above. Inguinal canal. In infants, the superficial and deep rings are superimposed. In adults, it is about 1.5 inches long, directed downwards and medially. In males, transmits spermatic cord, ilioinguinal nerve, and genital branch of genitofemoral nerve. In the female, have round ligament replaces the spermatic cord. Boundaries of inguinal canal. Posteriorly internal oblique, anteriorly internal oblique fibers, superiorly internal oblique and inferiorly inguinal ligament. Indirect inguinal hernia. It is the most common and it enters the preformed sac, which is partially or completely patent process vaginalis. Shortly before birth, the process vaginalis obliterates first at internal inguinal ring and then immediately above the upper pole of the epididymis. The tunnel of peritoneum between these 2 points become fibrous cord. Oblique inguinal hernia is of 3 types. Bubnocoel hernia. It is limited to the inguinal canal, occurs in young adults. Funicular hernia. Process vaginalis is closed only at lower end, just above the epididymis. The contents of these sacs can be felt separated from the testis, which lies below the hernia. It is common in adults. Complete hernia or scrotal hernia. There is a persistence of the prenatal condition before the process vaginalis is obliterated. Commonly encountered in infancy and may not appear till adolescent or adult life. The testes appear within the lower part of the hernia. Clinical features. It can occur at any age. Males are more affected when it is in bubnocoel stage. Sac is still in the canal. Diagnosis is difficult. Pain present in the groin or referred to the testis while doing heavy work or doing strenuous exercise. When coughs or transient bulging is seen and felt with an expansive impulse. When the hernia is large, swelling appears intermittently in the beginning. Sometimes it may appear during exertion and remain till it is pressed. Local pain is absent. As time goes on, the hernia comes down when the patient stands. In large hernia, there is sensation of weight and dragging on the mesentery may produce epigastric pain. In infants, the swelling appears when the child cries. In infancy and childhood, it is translucent. Treatment. Truss. When operation is refused or contraindicated, truss is used. Hernia must be reducible. A rat-tailed spring truss with a perineal band to prevent truss slipping will control a small-sized inguinal hernia. Worn immediately after get-up and hernia is reduced position. For a large irreducible hernia, a back truss is sometimes employed, but surgery is a must to prevent strangulation. Infant truss. Special inflatable rubber trusses are used in older days for hernia in infants. Operative treatment. The operation is the treatment of choice. It can be done in adults by local epidural or spinal anesthesia. The types of operation are herniotomy, herniorrhaphy and hernioplasty. Inguinal herniotomy. It is the basic operation. It entails dissecting out and opening hernial sac, reducing the contents and tying off the neck of the sac and removing the remainder. It may be the first step of the herniorrhaphy or hernioplasty. Herniotomy alone is sufficient in infants, adolescents and adults with strong inguinal musculature. In infants, it is not necessary to open the canal. Inguinal herniorrhaphy and hernioplasty. It consists of the excision of the hernial sac, herniotomy, and repair of the stretched internal inguinal ring, transversalis fascia, and reconstruction of the posterior wall of the inguinal wall by suturing and darning, or by facial sutures, facial flaps, tantalum bite, Dacron or Teflon net implants. Operative procedure. Herniotomy. Above and parallel to the medial to 2/3 of the inguinal ligament, an incision is made in the skin and subcutaneous tissue. In large irreducible hernia, the incision is extended into the upper part of the scrotum. After dividing the superficial fascia, external oblique aponeurosis and the superficial inguinal ring are identified. The external oblique aponeurosis is incised in the line of its fibers so as to open the inguinal canal. The structures below the external oblique aponeurosis are separated from its deep surface before completing the incision into the superficial ligament, inguinal ring. Now it is divided, hence the ilioinguinal nerve is safeguarded. By blunt dissection, upper leaf of the external aponeurosis is separated from the internal oblique. The lower leaf is dissected till the inner aspect of the inguinal ligament. The cremastic muscle fibers are divided longitudinally to open the subcremastic space and display the spermatic cord, which is hooked upon the forefinger. Excision of the sac. The sac is recognized as a fairly wide structure lying on the outer surface of the spermatic cord, and when the internal spermatic fascia is incised longitudinally, it can be dissected out and opened between hemostats. If the sac is small, it can be freed in toto. If it is long and funicular or scrotal, the fundus need not be sought. The sac is cut across in the inguinal canal, taking care of the vas and spermatic arteries, including the blood supply to the epididymis. An adherent sac can be separated from the cord by injecting saline through its posterior wall. Reduction of contents. Intestine or omentum is returned to the peritoneal cavity. If omentum is adherent to the neck, it is freed, and if to the fundus of the large sac, it is transfixed and ligated and cut across at a suitable site. The distal part of the omentum, like distal part of scrotal sac, can be left in situ. Isolation and ligation of neck of the sac. Whatever type of sac it may be, it is necessary to free its neck by blunt or gauze dissection till the parietal peritoneum can be seen on all sides. Then the extraperitoneal fat is encountered and the inferior epigastric vessels are seen on the medial side has the dissection reached the required limit. Otherwise, the sac is opened, the finger is passed through the mouth of the sac in order to make sure that no bowel or omentum is adherent. The neck of the sac is transfixed and ligated as high as possible, and the sac is excised 0.5 inches below the ligature. Repair of stretched internal ring. Lytis method. It is an important stage. The transversalis fascia is placated with unabsorbable sutures. The lateral of these displacing the cord laterally as much as possible and narrowing the diameter of the internal ring to the size of 3 mm. Lateral displacement of the stump of the sac. Usually the surgeon displaces the stump of the sac laterally below the arching fibers of internal oblique. A large curved round bodied needle threaded with each of the ends of the ligature used for transfixation. Closure of the neck of the sac is passed through the lateral fibers of the muscle from within outwards and tied without tension. Completion of operation. The cremasteric muscle is reconstituted if passed. The external oblique is directly sutured or overlapped, leaving a new external ring which will accommodate the tip of the little finger. Reconstruction of a weak posterior wall of the inguinal canal. First step, repair of stretched transversalis fascia, and if circumstances permit, to take the repair as far as laterally as possible and narrowing the remnants of the inguinal ring. It is same in the direct inguinal hernia also. Second step, two types of herniorrhaphy are possible. Reconstruction of posterior wall. The reconstruction with a flap of rectus sheet hinged on the linea semilunaris and sewn to the inguinal ligament. If further reinforcement is required, the external oblique aponeurosis is overlapped behind the spermatic cord, thus directing the structure into the subcutaneous patch at the site of the repaired internal ring. Halsted and Keynes modification. Reinforcement of the posterior wall by two-layer dawn. By using monofilament nylon steel wire, floss nylon or strip of fascia later, or by using sheets of foreign material like tantalum, gauze, dacron net, etc. Basinese operation. By suturing the conjoint muscle and tendon to the inguinal ligament behind the spermatic cord has been widely practiced. To obtain good results, the conjoint muscle and tendon must be well developed, and the space between it and the inguinal ligament must be narrow enough to permit approximation without tension. A relaxing incision in the rectus sheath is necessary to achieve this essential requirement. Unabsorbable suture like braided nylon are employed. The external oblique aponeurosis is reunited in front of the cord. That's all about the oblique inguinal hernia, and in the next video I will discuss about some other problems. Thank you.